So we undertook a large-scale study of looking at the utility of exome sequencing in adults and with CKD. But actually, the cohort that we studied, which was composed of 3,000 individuals from Columbia University and about 1,000 individuals who were from this clinical trial run by AstraZeneca called Aurora. There were altogether 3,300 individuals. Of those, 10% were in fact pediatric cases. And we wind up doing diagnostic annotation of these exomes based on the American College of Medical Genetics criteria for sequence interpretation. These are a set of guidelines that are used by all clinical laboratories to interpret the pathogenicity of variants, and they're designed to have a fairly low false positive rate. And you can see on the right, this is the distribution of age. 90% of them were adults. It was equal distribution of male and females. It was a multi-ethnic, multi-ancestry population, reflective of the diversity of patients with CKD that we see in the United States. And we saw we had a wide range of clinical diagnoses, congenital and cystic diseases, and glomerulopathies, which are relevant to the pediatric population, obviously, because these are the most common causes of kidney disease in pediatric cases. We also had many cases of diabetic kidney disease, hypertensive nephropathy, tubulointerstitial disorders. And of importance to this talk, also, we had about 10% of cases that had nephropathy of unknown cause, which is also a medically relevant entity in clinical practice. About 30% of the cases had a positive family history of kidney disease, consistent with what's been reported in the literature in patients with CKD. So this is the overall results of the study. The bottom line is that overall we had a diagnostic yield of 9.3% in this patient population. But if you look at the groupings and the clinical diagnoses that the patients came with, the diagnostic yield varied significantly. On the far right, you could see that if the patient came in with a clinical kidney disease, with about 1 to 2%. Whereas if you see on the far left, for and cystic kidney diseases, the diagnostic rate was almost 1 in 4. So there's a wide variation in the prevalence and the detection rate of kidney diseases, and so your pre-test clinical diagnosis really matters in terms of thinking about what is the diagnostic yield going to be. So glomerulopathies and tubulointerstitial diseases had a diagnostic yield that were somewhere around 4 to 8%, and the good surprise for us was that we had a positive diagnostic yield of 17%, so 1 in 5, 1 in 6 in patients with CKD of unknown cause. So when we looked at the overall predictors of a diagnostic yield, there were certain things that came out very clearly. I told you that this kidney disease subtype was very important and determined the diagnostic yield, and you can see here this is a summary from the literature that we published a couple of years ago. But also the presence of extrarenal features suggestive of syndromic disorder was also very important. The family history of disease was highly predictive of the positive diagnostic rate. And as it would make sense, a younger age of onset is really also predictive of a positive genetic diagnosis. So if you have these features together, then you should really think about, you're going to have a high diagnostic rate. So also, in terms of the distribution of disease disorders that we encountered, we found altogether 66 distinct monogenic disorders in this 307 patients that had one of these monogenic disorders, but it was not evenly distributed across this population. There were essentially 6 genes that we encountered over and over again, accounting for about 66% of diagnoses, or 2/3 of diagnoses. So PKD1 and PKD2 diagnostic of polycystic kidney disease, the autosomal dominant form, type 4 collagen mutations diagnostic of thin basement membrane disease, Alport syndrome, uromodulin mutations diagnostic of autosomal dominant tubulointerstitial disease, and then the 1/3 of patients had mutations in 60 different genes. So essentially these were all rare diseases, N of 1 and 2s. And most of them were not picked up by clinic, and those in the clinical evaluation, and these were distributed across the spectrum of glomerulopathies, tubulointerstitial diseases, and congenital disorders. So these are really rare diseases that we encountered in clinical practice. As I said, most of them were not diagnosed based on the standard clinical evaluation. So let me give you an example. This is a patient I saw recently. This is a 43-year-old who was diagnosed with proteinuria and was nearing end-stage kidney disease. He was admitted to the hospital. He has a mother and an uncle with end-stage kidney failure. The patient is African American, and so the working diagnosis that he had some form of FSGS or hypertensive associated nephropathy associated with an APOL1 risk allele. And so we still wind up, because of the family history, we still wind up doing genetic testing. And it turns out that he had a heterozygous variant in the type 4 collagen gene called 4A3, which was diagnostic of a dominant form of Alport syndrome. In his case, essentially, he had probably some form of FSGS and thin basement membrane disease to the spectrum of Alport syndrome. And this is one of the most frequently encountered diagnoses in clinical practice nowadays. And so most of these patients come in with a potential diagnosis of FSGS. They're put on a course of steroids, but to no avail, of course, because this doesn't work for structural defects of the kidney. So the treatment for this patient is to avoid steroids, refer for a clinical trial if possible, screen family members who are at risk, and counsel him. So the clinical presentation of classic Alport syndrome is blood in the urine, sensorineural deafness, some pathognomic findings on kidney biopsy, some ocular findings. And Alport syndrome is attributable to mutations in one of three genes: the classic X-linked form due to mutations on COL4A5 on chromosome X, and then the dominant or recessive forms due to mutations in COL4A3 and A4 on chromosome 2. It turns out the dominant forms of Alport syndrome, patients carrying heterozygous variants in these COL4A3 and COL4A4 genes, are pretty prevalent in patients with chronic kidney disease. They present typically pretty later on in life, and they tend to be misdiagnosed. So in fact, when we looked at our study, looking at the prevalence of what is the distribution of the clinical diagnoses that the patients with the type 4 collagen mutations look like. So altogether, we had 92 such cases with pathogenic variants in COL4A3, A4, or A5, and only 38% of them presented with a clinical diagnosis of Alport syndrome, a thin basement membrane disease, whereas the others had a diagnosis of CKD of unknown cause, glomerulopathy not otherwise specified, or FSGS, or congenital defects. So this really told us that the most common presentation with these mutations is not really your classic Alport syndrome, but all these non-specific findings, and particularly for that subset that gets diagnosed with FSGS, that's important to be aware of them, because they may get exposed to immunosuppression with no benefit, but only expectation that they would get side effects from them. So something to really remember and have a high index of suspicion for. So let me tell you about another example. This is a 25-year-old with a history of kidney disease ever since childhood. He had had kidney biopsies at age 8 and 11. They were non-diagnostic. He was progressing slowly. He had two brothers who also had the exact same thing. He was getting married and wanted to know whether there's a risk of this disease being transmitted to his children. And so rather than doing another kidney biopsy, we wound up doing exome sequencing, which revealed that he had a diagnosis of Dent's disease, which is a really rare tubulopathy associated with tubular proteinuria due to mutations in this gene, CLCN5. And so this disorder is associated with low molecular weight proteinuria, hypercalciuria, bone loss, nephrocalcinosis, which then leads to the kidney failure. And so we made the exact same diagnosis in his brothers. This is an X-linked disease. And so we were able to counsel the patient, first of all, to tell him that he would be transmitting this mutation to his daughters, but because it's an X-linked disease, most women do not present with any symptoms when they inherit this mutation, and so that should be okay, and his sons would not be at risk, basically. And in addition, what's important is that there's a treatment here with thiazide diuretics and a high citrate diet, and we referred him also for bone density studies because he actually had at age 25 a history of fractures, and so this is due to the hypercalciuria and bone loss that's associated with it. So we could make a comprehensive diagnosis here and provide an answer to this family, which had this issue, since childhood, essentially. So this is a patient basically that had CKD of unknown cause. And so, as I said, we had a diagnostic yield of about 1 in 5, 1 in 6 in our patient populations with CKD of unknown cause.